A 67-year-old man sat down in my office last month, reached into a plastic grocery bag, and lined up 9 prescription bottles on my desk like chess pieces. He looked at me and said, "I take everything my doctor tells me to." He said it with pride. I looked at that lineup and felt something closer to dread. Here is what nobody explained to this man. After 65, the same medication that kept you stable at 45 can quietly destroy your kidneys, drain your bone density, or fog your brain so badly your family starts whispering the word dementia. These are not bad drugs. Many of them saved lives when they were first prescribed. The problem is that your body at 65 processes medication completely differently than it did 20 years ago. Your liver slows down. Your kidneys clear drugs less efficiently. Your fat-to-muscle ratio shifts. Drug half-lives stretch out. A dose that was perfectly safe at 50 can accumulate to toxic levels at 68 without a single person adjusting a single pill. What you are about to hear are 6 categories of widely prescribed medications that I, as a physician, would personally refuse or demand alternatives for after 65. Not because a textbook told me they are dangerous, but because I have watched what they do to this age group over 15 years of clinical practice. Subscribe and hit like right now. The system profits when you stay on 10 pills forever. Nobody in a waiting room is going to have this conversation with you. Help Dr. Johnson reach 100,000 subscribers. Every single one counts. To understand why these medications become dangerous, you first need to understand what happens to your body's ability to handle them. Your liver is your body's primary drug processing plant. The enzyme system responsible for breaking down the majority of medications is called cytochrome P450. By 65, that system has lost roughly 30% of its processing capacity. That means drugs that used to be metabolized and cleared efficiently now linger in your bloodstream significantly longer than they are supposed to. Your kidneys tell the same story. Your glomerular filtration rate, that is the speed at which your kidneys filter waste and medications out of your blood, declines steadily with age. Drugs that rely on kidney clearance do not leave your system on schedule. They accumulate, dose after dose, day after day. Levels creep upward and nobody notices until symptoms appear. Then there is body composition. After 65, you carry proportionally more fat and less water than you did at 40. Fat-soluble medications now have a larger reservoir to dissolve into. They hide in your fat tissue and release slowly, extending their effects in ways that are difficult to predict. Water-soluble drugs face the opposite problem. Less total body water means the same dose concentrates in a smaller volume. It hits harder than it should. And here is the one almost nobody talks about. Your blood-brain barrier, the protective filter that controls what gets into your brain, becomes more permeable with age. Medications that never once affected your thinking at 40 can now cross into your brain and cause confusion, dizziness, memory lapses, or falls. You blame it on aging. Your family worries. But the actual cause is sitting in your medicine cabinet. Your prescriptions may not have changed in 10 years, but your body changed completely and nobody updated the math. By the way, if you are looking for a natural way to support your cardiovascular health and metabolism as you age, Cardio Slim Tea is currently available at a special discount. The link is on the channel page. Now, let us get into the 6 medications. Medication number 1, proton pump inhibitors. You know them as omeprazole, esomeprazole, pantoprazole, the acid reflux pills that millions of people pop every single morning like a vitamin and never think about again. Here is how they work. Your stomach lining contains tiny pumps that produce hydrochloric acid. PPIs shut those pumps down. For healing an ulcer or calming severe reflux over 4 to 8 weeks, that is brilliant medicine. The problem is, when 4 weeks turns into 4 years, then 10 years, and nobody ever revisits the decision. Because stomach acid is not your enemy. It is essential machinery. Your body needs that acid to absorb calcium, magnesium, iron, and vitamin B12. Suppress it for years, and you get progressive nutrient depletion that builds so gradually, nobody connects it to the pill. Calcium malabsorption directly accelerates osteoporosis. After 65, your bone density is already declining. Now add a drug that blocks calcium absorption on top of that, and studies show a measurable increase in hip fracture risk. Magnesium depletion causes muscle cramps, cardiac arrhythmias, and a fatigue that no amount of sleep fixes. Emerging research connects prolonged PPI use to increased risk of chronic kidney disease and even cognitive decline. And there is one more. Without proper acid levels, your gut microbiome shifts dramatically. The door opens to Clostridioides difficile infections, a bacterial overgrowth that is particularly dangerous and sometimes fatal in older adults. A drug designed for short-term use should not become a decade-long habit. Talk to your doctor about tapering. Ask about H2 blockers, a lighter class of acid reducers. Address the root cause, whether that is a hiatal hernia, dietary triggers, or eating patterns. Your stomach acid exists for a reason. Shutting it off permanently was never the plan. Medication number 2, benzodiazepines. Diazepam, lorazepam, alprazolam, the anxiety and sleep medications that are still prescribed at alarming rates to people over 65. Here is the mechanism. Benzodiazepines enhance the effect of GABA, your brain's primary inhibitory neurotransmitter. Think of GABA as the brake pedal for your nervous system. These drugs press that pedal harder, slowing neural firing across the board. In a younger brain, with robust compensatory mechanisms, the result is calm, relaxation, and sleep. In a brain over 65, with reduced neurotransmitter reserves and a blood-brain barrier that has become more permeable, the result is something entirely different: oversation, cognitive impairment, and a dramatically increased risk of falls. There is an established list in medicine called the Beers criteria, a compilation of medications considered potentially inappropriate for older adults. Benzodiazepines are flagged prominently on that list. The reason is a sequence I have watched unfold too many times. The drug causes dizziness. The patient falls. The fall fractures a hip. The fracture requires surgery. Surgery means immobilization. Immobilization leads to pneumonia, blood clots, muscle wasting, and cognitive decline. That sequence kills people. It does not start with a disease. It starts with a pill. On top of that, long-term benzodiazepine use creates physical dependence, and withdrawal in older adults is not just uncomfortable, it can trigger seizures. These drugs were never designed for nightly use. They were designed for short-term crisis management. After 65, the risk-benefit equation flips entirely. The calm they provide is not worth the fall they cause. Alternatives exist. Cognitive behavioral therapy for insomnia works without chemistry. Sleep hygiene protocols cost nothing. Low-dose trazodone or melatonin under medical supervision can bridge the gap. Ask your doctor. Because sleeping through the night means nothing if you break your hip getting out of bed in the morning. Medication number 3. Anticholinergic medications. This is the category most patients have never heard of, and yet many of you watching right now are taking one or more without knowing it. Anticholinergics block acetylcholine, a neurotransmitter critical for memory, muscle control, and dozens of essential bodily functions. The list of drugs with anticholinergic effects is vast and genuinely surprising. Certain antihistamines like diphenhydramine, which is the active ingredient in many over-the-counter sleep aids people buy without a prescription, bladder medications like oxybutynin, older antidepressants like amitriptyline, even some medications for nausea. Here is the concept nobody explains to patients. It is called anticholinergic burden. Each individual drug may seem mild on its own, but when a patient is taking 2 or 3 medications that all carry anticholinergic effects, the cumulative load on the aging brain becomes enormous. And after 65, with a more permeable blood-brain barrier and fewer neurotransmitter reserves, that load lands harder than it would in a younger person. Research links high anticholinergic burden in older adults to increased risk of dementia, confusion, constipation, dry mouth, blurred vision, falls, and here is the irony: urinary retention, the exact opposite of what the bladder medication was prescribed to fix. Let me show you how this plays out. A 70-year-old woman takes diphenhydramine for sleep, oxybutynin for bladder urgency, and amitriptyline for mood. 3 anticholinergics stacking on top of each other. 3 different prescribers, nobody connected the dots. She comes in complaining of memory problems, and her family is terrified it is early Alzheimer's. It is not, it is her medicine cabinet. Ask your pharmacist to run an anticholinergic burden score on your full medication list. There are almost always newer alternatives with lower anticholinergic activity. You just have to know to ask. Medication number 4, NSAIDs taken daily. Ibuprofen, naproxen, diclofenac. The painkillers most people treat like vitamins. A knee aches, take 2. Back stiffens up, take 2 more. Every single day, year after year. After 65, daily NSAID use becomes a serious gamble with 3 organ systems simultaneously. First, your stomach. NSAIDs inhibit COX-1 enzymes that produce the protective mucus lining of your stomach wall. Without that lining, your own stomach acid eats into exposed tissue. Gastrointestinal bleeds in older adults are not rare events. They are emergency department regulars, and they can be fatal. Second, your kidneys. NSAIDs reduce blood flow to the kidneys by blocking prostaglandins, the compounds that keep your renal arteries dilated. In a 40-year-old with healthy kidneys, that is a temporary, reversible dip. In a 68-year-old whose glomerular filtration rate is already declining, it can tip kidney function into dangerous territory, especially if that patient is also taking blood pressure medications or diuretics, which most people in this age group are. Third, your heart. NSAIDs increase blood pressure and promote sodium and water retention, adding strain to a cardiovascular system that is already working harder than it used to. Now here is the interaction trap that I see constantly. A patient takes lisinopril for blood pressure, a diuretic for fluid retention, and then adds daily ibuprofen for arthritis. That single addition undermines both of the other medications simultaneously. The blood pressure creeps up, the fluid retention worsens, the kidneys take the hit from all three directions. Nobody told the patient because nobody looked at the full picture. Alternatives exist. Topical NSAID gels applied directly to the joint deliver relief with far lower systemic absorption. Acetaminophen at appropriate doses. Physical therapy. Joint-specific exercises. Corticosteroid injections when warranted. Your joints need help. Your stomach, kidneys, and heart do not need to pay the price for it. Medication number 5. Statins. And this one requires nuance. Because I am not here to tell you that statins are bad. Statins save lives. That is not in dispute. The problem is specific. High-dose statins after 65 and certain dangerous combinations that nobody flags until symptoms appear. Here is the mechanism. Statins block an enzyme in the liver called HMG-CoA reductase, which reduces cholesterol production. At standard doses, the benefit-to-risk ratio is generally favorable. But at high doses in older patients, the risk of myopathy increases significantly. Myopathy means muscle pain, muscle weakness, and in severe cases, muscle breakdown. When that breakdown becomes severe, it progresses to a condition called rhabdomyolysis, where disintegrating muscle tissue floods the kidneys with a protein called myoglobin. That can cause acute kidney failure. Now add drug interactions to the picture. Certain antibiotics, antifungals, calcium channel blockers, and even large quantities of grapefruit juice all interfere with the same liver enzymes that metabolize statins. After 65, with liver metabolism already running at 70% capacity, these interactions become significantly more dangerous. The statin does not clear on schedule, levels build, muscles pay the price. There is also the cognitive side. Some patients report brain fog, memory problems, and confusion on statins. The research is mixed, and I will not overstate it. But in a patient over 70 who is already noticing mild cognitive changes, that warrants a direct conversation with their doctor. Not panic, a conversation. The message here is not stop your statin. The message is ask whether your current dose is still appropriate for your current age, your current kidney function, and your current medication list. A dose that was exactly right at 55 may need adjustment at 70. Bodies change, prescriptions should change with them. Medication number 6, muscle relaxants. Cyclobenzaprine, methocarbamol, tizanidine, commonly prescribed for back pain and muscle spasms, commonly disastrous after 65. These drugs do not work at the muscle. They work centrally, in the brain and spinal cord, suppressing the nerve signals that cause muscle contraction. That is an important distinction. You are not relaxing a tight muscle. You are sedating your entire central nervous system to quiet the signal. In a younger adult, the sedation is manageable. In an older adult, it is profound. Drowsiness, dizziness, confusion, impaired coordination. Every single one of those translates directly to fall risk. And we have already established what a fall means after 65. Fractured hip, surgery, immobilization, the spiral. Cyclobenzaprine deserves a special mention. Remember the anticholinergic burden we discussed earlier? Cyclobenzaprine has strong anticholinergic properties. That means it is not just sedating the brain, it is actively blocking acetylcholine on top of the sedation. If a patient is already taking other anticholinergic medications, this drug compounds the cognitive load in ways that mimic early dementia. And here is the detail that makes this particularly dangerous. The half-life of cyclobenzaprine extends significantly in older adults. The drug is still active in your system long after you think it has worn off. A dose taken at bedtime for back pain can leave you groggy and unsteady at 7 in the morning, precisely when you are getting out of bed and navigating to the bathroom in the dark. That is the single highest risk moment for a fall. Muscle relaxants treat a symptom, the spasm, while creating a far more dangerous problem, falls and cognitive impairment, in exactly the population least equipped to recover from either. Alternatives exist: targeted stretching, heat therapy, physical therapy, low-dose topical analgesics applied directly where it hurts, gentle, consistent movement protocols. Your back needs relief. Your brain does not need to be shut down to provide it. Now I want to step back from individual medications and talk about something more dangerous than any single drug on this list: the combination. In medicine, the term is polypharmacy. It means taking 5 or more medications simultaneously. That applies to roughly 40% of all adults over 65. Here is the part that should concern you. Each of those drugs was tested individually in clinical trials, usually on younger patients. Nobody tests 8 drugs together in a 72-year-old. That experiment happens in your body, unmonitored, every single day. Drug interactions in older adults are not edge cases, they are the norm. Let me walk you through a scenario I see constantly. A patient takes lisinopril for blood pressure, a statin for cholesterol, omeprazole for reflux, a daily aspirin for cardiovascular protection, diphenhydramine for sleep, and ibuprofen for arthritis. 6 medications. 6 doctors over the years said yes. Nobody looked at the full picture. The omeprazole depletes magnesium, which affects heart rhythm. The ibuprofen undermines the blood pressure medication and strains the kidneys. The diphenhydramine adds anticholinergic load to a brain already dealing with the statin's cognitive effects. The aspirin combined with the NSAID doubles the risk of a gastrointestinal bleed. Every drug is doing something to another drug, and the patient thinks each pill is working independently, and then comes the cascade. A drug causes a side effect. That side effect gets treated with another drug. That drug causes its own side effect. Another prescription follows. The pill count grows, and nobody ever subtracts. Schedule a comprehensive medication review, not a quick refill appointment, a full reconciliation of every pill, every supplement, every over-the-counter product, evaluated as a system. Your pharmacist can do this. Ask for it by name, because the most dangerous drug interaction is the one nobody checked for. This brings us to the conversation most patients never have: deprescribing. The word sounds clinical, but the concept is simple. It is the systematic process of identifying medications that can be safely reduced or stopped because the risks now outweigh the benefits. Not because the drug was wrong when it was started, because the situation has changed. Here is the barrier I see every day. Patients are afraid to question their doctor. They feel it would be disrespectful or that they are not qualified to ask. And on the other side, doctors are often too busy to initiate the conversation themselves, or too cautious to remove a medication another physician prescribed. So pills accumulate. Nobody adds, nobody subtracts, and the list only grows. I want to give you the exact language to use at your next appointment. Say this: "Doctor, I would like to review whether each of my medications is still necessary at my current age." That single sentence opens the door. A good doctor will welcome it. If your doctor feels threatened by that question, that tells you something important about your doctor. One critical point: deprescribing is not the same as quitting cold turkey. Many medications, benzodiazepines especially, require gradual tapering under supervision. Stopping abruptly can cause withdrawal symptoms, rebound effects, or in some cases, seizures. This is a process you do with your doctor, not instead of your doctor. And use your pharmacist. Pharmacists are the most underused resource in the entire healthcare system. They can run interaction checks, calculate anticholinergic burden scores, and flag high-risk combinations that the prescribing physician may never have considered together. Your medication list should shrink as you age, not grow. Every drug you no longer need is one less side effect, one less interaction, and one less risk of a fall, a bleed, or a hospitalization that did not need to happen. Let me tie this together. We covered 6 categories of medication: proton pump inhibitors that starve your bones of calcium, benzodiazepines that sedate you into a fall, anticholinergics that silently fog your brain, NSAIDs that attack your stomach, kidneys, and heart simultaneously, statin doses and combinations that break down muscle tissue, and muscle relaxants that shut down your central nervous system to treat a backache. Every single one of these carries a different level of risk depending on your age. The same drug your body tolerated without complaint at 45 can generate real measurable damage at 68. Not because the drug changed, because your liver slowed, your kidneys declined, your body composition shifted, and your blood-brain barrier opened wider. Your body became a completely different machine, and your prescriptions stayed frozen in time. How old are you? Write it in the comments. I want to see which age group is most affected by these medication risks because it directly shapes what I cover in future videos. Now, here is exactly what to do tonight. Go to your medicine cabinet and gather every prescription bottle, every supplement, every over-the-counter product you take. Write the full list on a single piece of paper. Tomorrow, call your pharmacy and ask for a medication interaction review. At your next appointment, bring that list and ask your doctor 3 questions. Is this medication still necessary at my current age? Is this dose still appropriate for my body right now? Is there a safer alternative? 3 questions. That is all it takes. This is not about fear. You are not sick. You are informed. And informed patients live longer than compliant ones. Now, the theme of everything we just covered comes down to one idea. After 65, your body needs fewer chemicals forcing it into artificial rhythms and more support for the systems that are actually struggling. Your metabolism, your cardiovascular system, your circulation, your inflammatory response. That is not a poetic statement. It is the physiological reality we walked through in every single chapter. This is exactly why I want to tell you about something I personally stand behind. Cardio Slim Tea is a carefully formulated blend designed to support exactly those systems. It targets cardiovascular function, healthy metabolism, and the kind of gentle, sustained circulatory support that becomes critical after 50. The ingredients are selected for their effect on blood vessel flexibility, metabolic efficiency, and inflammatory balance, the exact areas where the medications we just discussed cause the most damage. What changes when these systems are properly supported? Sleep improves because your circulation is not fighting against you at night. Energy stabilizes because your metabolism is not being artificially suppressed or spiked by drug interactions. Joint stiffness eases because inflammation is managed at the root, not masked with painkillers that destroy your stomach and kidneys. Your cardiovascular system gets daily, consistent support instead of being battered by a pile of competing prescriptions. This is not a replacement for medical care. It is the foundation underneath it, the thing that should have been in place before anyone reached for a prescription pad. Right now, there is a special offer available. The link is on my channel page. You can get there by clicking my channel name or profile picture below this video. If you are watching on your phone, tap my profile picture and it will take you directly to the channel page. A screenshot is appearing on screen right now showing you exactly where to find it. You can also scan the QR code on screen. Open your phone camera, point it at the square, and tap the link that pops up. It takes you straight to the page.